Case D, we have a 35-year-old female who's unresponsive, lying on the living room couch. So we get a history that the patient has a history of chronic pain. She had an MVC about 10 to 15 years ago. The exact time doesn't matter, but she's in pain management and follows with the pain management doctor. Husband who meets you at the door, he came home to find her unresponsive. An unknown time. He's been out of the house for several hours. There's some dried emesis. In the corner of her mouth. No other past medical history other than the chronic pain, and the patient can't tell you what's going on, can't give you a history of present illness. So what do we see when we examine her? She withdraws to pain. That's not good. She doesn't wake to voice. She doesn't wake to tactile stimulus, but she does withdraw to painful stimulus. His skin is warm and flushed. It is dry. Pupils are dilated. A couple key things there. You look in her mouth and her mucous membranes are dry. She's tachycardic. Let's see, blood pressure, she's hypotensive at 80/46. Her pulse is 120. It's weak. She's breathing at 8, shallow. SAT is 88% on room air, and her temperature is 99.6. So, any other diagnostics or assessments indicated in this patient? Well, one thing that could be offered is a 12-lead EKG. Let me switch over to that image there, and we'll bring that image to where we can see that. So here's her EKG. One of the things that we see significant on this is, man, her QRS is pretty darn wide. Those T's are very peaked. She's tachycardic. This is a very concerning EKG. This is a very concerning EKG. Now, what are some things in the history that kind of helps decipher this in terms of your differential? She's got a little bit of an elevated temperature. She's hypotensive. She's tachycardic. Is this sepsis of some sort? Not sure. She's altered, but she's not breathing very quickly. She's not breathing normally. She's bradypneic. Sepsis, usually that'll increase your respiratory rate, so I'm not sure about that. She's got a history of chronic pain. She sees pain management. There's a lot of different medications that are used. Is there an opiate overdose? Well, her pupils are they're not normal. They're not constricted. They're actually dilated. So that definitely doesn't suggest opiate overdose. But do we have other overdose that's in there? Patients who have chronic pain, a lot of times, most of the time, they do become depressed. There's certain medications that are used to help as adjuncts to opiate medications for pain. Tricyclic antidepressants are kind of the first generation of antidepressants. They're not used as much anymore for depression, but they do help modify the pain pathways, and so a lot of chronic pain providers place their patients on either tricyclic antidepressants or SSRI antidepressants. So that's definitely a possibility. There may be some other medication, so we need to get a medication list. But a lot of this, and especially combined with the EKG, is pointing towards a tricyclic antidepressant. So what are our treatment priorities? We definitely need some IV fluids. The antidote for tricyclics is sodium bicarb. And not because the patient is acidotic, but because tricyclics are sodium channel blockers. So they block the sodium channel in the heart. That's what causes the widened QRS. So sodium bicarb is our treatment to displace the sodium channel blocker, and that can be given in 1 amp doses. And how do we know that we've given enough? The QRS narrows and becomes normal in size. So, we may need to give oxygen. She's hypoxic. She's bradypneic, so bag valve mask ventilation is definitely indicated. She is too altered to put her on CPAP or BiPAP, so BVM is indicated. Perhaps she will get better and perfuse better after the sodium bicarb goes in. So that might be reasonable to if you have the resources to only do bag valve mask, and then intubation may end up being necessary to secure that airway. She's got dried emesis in the corner of her mouth, which is kind of concerning for aspiration. So intubation may be an appropriate thing. In terms of the reevaluation, looking at the 12 lead, now the patient's going to be monitored, so watching on the monitor strip is helpful. But if we look at her after treatment 12 lead, we notice that the QRSs now are much narrower. That looks a lot better. We still have our peaked T waves, but when we compare, just to get that within the screen there, when we compare the two EKGs, there's a pretty marked difference there. So that's good. We're going in the right direction. We're not quite there yet. The QRS is still a little on the wide side, so she's going to need some additional sodium bicarb. So following the 12 lead, following vitals, end-tidal CO2, and seeing where she goes with this. What's the appropriate disposition? Well, we're concerned about an overdose. This may be intentional, this may be accidental. We can't question her to know. Honestly, it doesn't matter at this point. Her medical condition takes priority. So any hospital, it honestly does not matter whether the hospital that you bring the patient to has an inpatient psychiatric service. This is someone who needs to be taken care of medically. They need to go to the ICU. They need to go to the closest hospital. The psychiatric evaluation issues can be undertaken once the patient is stabilized. That's going to take a couple of days for this patient to be stabilized. So any hospital, closest hospital, is perfectly acceptable. Now, if you're in an urban environment and you've got a choice of a couple different hospitals and the ICUs are comparable, and it's not too much of a distance, you may choose that hospital that has the psychiatric services. However, you really shouldn't be bypassing more than a couple of minutes to go to another hospital. That puts the patient at risk. That's a patient safety issue.